My name is Dr. Reed Tuckson, co-founder of the Black Coalition Against COVID, and it is my absolute privilege to welcome you to this special edition called Vaccine Confidence, COVID-19. The purpose of this conversation today is for Black healthcare professionals by Black healthcare professionals. We learned and know that when we took our oaths, whatever our particular discipline is in healthcare, we took an oath to make sure that we established and maintained and enhanced a trusting relationship with the people that we are privileged to serve. We also made an oath that implied without ambiguity that we have a responsibility to engage in continuous learning so that we will be able to translate our expertise into service to and discourse with our society. We learned a lot during the pandemic. We learned a lot about things that we do well, and we learned things that we need to do better. We learned that we have a very hard and challenging opportunity to better engage with our communities so that we can help them to make the best evidence-based, personally appropriate choices for themselves, their families, and their communities. And we also learned that we as health professionals have our own challenges to be able to learn how to better communicate, as well as the challenges that confronted us during the pandemic from the perspective of clinical care delivery. Well, we're going to talk tonight about these issues, how we can do better, how we can be better, and how we can help our community to be able to optimize their health outcomes, not just for pandemics like COVID, but also because of the pre-existing and unfortunately continuing experience with preventable chronic illness. We're very pleased that Moderna has sponsored this conversation, and I'm very pleased that our colleagues are joining us tonight. First, let me introduce Dr. Virginia Caine. Virginia Caine is the 125th president of the National Medical Association. She serves in her regular work as the director and the chief medical officer of the Marion County Public Health Department. She also serves as an associate professor of medicine at the Indiana University School of Medicine Infectious Disease Division. I'm also pleased that Dr. Randall Morgan is joining us, the president and the CEO of the W. Montague Cobb Institute. Dr. Morgan also served as the 95th president of the NMA, graduate of Howard University College of Medicine, and a student of Dr. Cobb, a board-certified orthopedic surgeon as well. And now I'm also pleased that Dr. Lauren Dungy-Poythress is also joining us. Dr. Poythress is a maternal fetal medicine specialist, as well as an associate professor at the Indiana University School of Medicine. She's designed, developed, and led successful maternal fetal medicine offices and/or programs in 3 states. She's an active lecturer, motivational speaker, frequent television guest, and who has a special interest in equity, inclusion, and disparities in healthcare. Welcome to all of our panelists, and I do hope that the audience will take good advantage of the question and comment section, and certainly let us know what your comments and also maybe questions that we will work very hard to be able to address near the end of the program. So we look for that conversation contribution from you. Well, to begin our conversation, we want to turn to the issues of what we have learned in terms of community-oriented lessons learned from the recent pandemic. And let me start with my panelists. What have we learned about why it was so difficult initially to get the Black community to heed COVID prevention guidance, and when made available, to be able to take the COVID vaccines? Who wants to start us out?
Well, first I can start, and let me just say I have no disclosures for any pharmaceutical company starting my conversation. Well, unfortunately, we've had long-term racial injustice and cultural insensitivity experienced by a lot of minorities, which has supported a much higher level of COVID-19 vaccine hesitancy. And as a part of that, we've also seen a tremendous amount of misinformation that has been spread related to the COVID-19 vaccine, and this disinformation has played a role in terms of our Black community feeling, well, also taking this vaccine. And then we also always have the issue of access. And so, how many of our patients have access to a primary care provider where they can get the correct information or be educated about the vaccine safety and profiles? And let's be honest, some patients just have a fear of needles. So, it's got nothing to do with the COVID-19 in itself. And the last reason I will put out there, and Dr. Morgan or Dr. Dungy can add this, people felt that the vaccine was rushed and that it was developed so quickly. Can it really be safe because it was developed so rapidly? And so that's questions I always had constantly from my patients related to the vaccine
Well,
hesitancy.
that's just a completely great set of issues, and it certainly resonates well with my experience. Lauren, you have worked with a very special population of people where you would think that pregnant women would be very much invested in what's going to happen to themselves and perhaps their babies. What were your challenges?
Well, certainly they are very invested, and because they're very invested, what potentially could be the effect of this vaccine that people felt were rushed and that there weren't any pregnant women in the initial studies? Is it going to be safe for my baby? Primarily were the concerns. It wasn't about what I need to be safe for me. I take this medicine and then I get some unfortunate birth defect or abnormality with my baby. And we just didn't have those answers initially when it came out.
And Dr. Morgan, Randall, when your experience as well in terms of your counseling your patients, what were the key frustrations that you were experiencing?
Well, I think Dr. Caine spoke about access, and that has been pervasive. Many of my patients did not have the proper conversation with their primary physician. I'm a subspecialist, so I wasn't not at the first line of care many times. And so they didn't feel confident about what they heard. So it took a while to sort of restate our challenge. And of course, we didn't know as much as we know now. So we were going by good medical principles, but we had to go and explain to our patients that vaccination has been a major part of good public health for 200 years in the United States, and that we have the proper experts, including African Americans, who were very involved in the development of the vaccines. And with time, with confidence, we began to make way, I think, with our patients so that the confidence level increased.
You know,
but it didn't happen right away.
One of the things that people don't realize, and too many people in the public don't realize, and in Black community don't realize, that for the first time in history, we closed the disparities gap when it comes to primary series vaccination. What also I think will be a surprise to many people, not to this audience maybe, is that in the second year after the vaccine was made available, Black life expectancy was better than white America's. So, Dr. Caine, what do you think? Randall sort of kind of started to get into that. What was it, do you think, that made the difference in moving from so much misinformation, so much resistance and distrust to a place where we actually were able to close the disparities gap?
So I think the first thing, that when this vaccine was first available, it was available to hospital systems and local and state health departments, but it was not available to the doctors out there in practice, in the doctor's offices initially. So we missed a golden opportunity where our patients might have been going to hospital systems where they normally get their vaccines in their doctor's offices. So they were going to maybe sometimes new settings where they normally otherwise would not do. And so later on, when we had vaccines available to our providers, people of color, who we're known as the trusted messenger, okay? And so we saw a major shift as more of our Black healthcare professionals start doing education to our patients. But let me tell you the second major issue. We're always telling patients, hey, you got to come to us. No, we need to go where the patients are. And a lot of our Black providers were located, their offices were located where the patients we needed to reach. And we knew that health departments, for example, start having mobile vaccination units going to where the patients resided, not forcing them to have to come. Wow, you got to get on a bus and it takes you a whole hour or longer to get your vaccine, you know. And so we did a better job of educating our patients, but also we learned that social media is critical. So getting on the radio, doing our podcasts, being available and participating in health fairs made a huge difference, I think, in turning the corner where people had access, where they could talk to a healthcare professional that they trusted
Yes.
to learn more about the information.
Randall, one of the things that what Virginia is saying here is, and that I really think is important, is that I was very impressed with the number of our brothers and sister physicians who actually left the clinical arena and went into the community itself and engaged. And I know that the Cobb Institute, along with the NMA, did a lot of that work. Can you just sort of describe sort of what that was about, how you all structured and organized your engagement, in the community itself with community-based partners?
Well, certainly, I think one of the very first things that we did was to build coalitions, working with the National Medical Association, the historically Black colleges and universities of medicine, the Black nurses, and the clergy, to come to common ground in terms of what strategies we might use. Then we also had opportunities with the Cobb Institute to promote participation in clinical trials for vaccines. And so we had to develop really the message and actually take that to the community, and were successful in increasing the percentage of enrollment for particularly the Johnson & Johnson vaccine. The other two had actually been already released by the time the Cobb Institute became involved. And then the third thing is to go to cities, and particularly about 30 cities where there was a very high level of vaccine mistrust and distrust, and where there was a lack of concordance among the providers and the patients. And almost one by one on Saturday mornings, we would have programs that would give patients a chance, individuals a chance to ask questions. And we'd always have at least one, if not more, trusted voices there from their community. And I think that's really when we started to make a difference.
I think also that one of the partners, at least that I know, that were very effective in the work that we did at the Black Coalition Against COVID was the faith community. Do any of you have any thoughts on what we learned about the role of the partnering between the Black health professional and the Black clergy?
So let me just say, in Indianapolis, we put together about 30 faith-based pastors, ministers, some Latino, some white, but the majority were Black. And our president of city council, who was an African American, along with our mayor of Indianapolis. And we actually got vaccinated in front of the television networks all at the same time. And I think that was critical, because then they can see long-term and monitor and follow us to see that we were healthy. We were not succumbing to being required to be hospitalized. So they could see visually that we trusted enough with this vaccine that we took it publicly for people to see. And that was huge for us, but it was huge that we had our faith-based partners willing to make that commitment and to be vaccinated on television for their constituents and their congregational members to see that.
Well, I think that's a key lesson. I would hope that that we would all agree that one of the lessons that we have learned about working with community is to partner more actively with our faith-based brothers and sisters. I think that one of the things that I noticed the effectiveness of was to have the physician or the health professional side by side with the pastor at the church, and so the pastor not leaving after he introduces the health professional, but staying side by side. And I think that might be a lesson that we can take. But let me ask you all a challenging question. And Lauren, I don't know whether you might have a thought on this or Randall or Virginia, but it's this. One of the things that I was pleased to do was to observe blackdoctor.org, for example, with its multiple town halls that it did. But we mainly did those town halls with faith-based groups, the Divine Nine, the Jack and Jills, the organized infrastructure of Black life. There are so many other of our brothers and sisters who are not part of the organized infrastructure. They're in what I call almost an unincorporated zone. They don't belong to the traditional organizations and societies. Lauren, I mean, any thoughts on what can we learn from the challenges of reaching them?
Well, I think, as you all have pointed out, relationship is very important. The reason the faith-based activities worked is because people trusted their pastors and the people in the church that they met with on a regular basis. And the more we can reach out and build those relationships before a crisis occurs and build that trust and build those relationships, I think the better off we'll be in sharing the knowledge. Knowledge is power. We share it with the people, and we can get, I think, a little further than we have been.
Good.
I think the thing is having resources out there and making those resources available to anyone who wants to provide education. We were able to do that here in Indianapolis, where we gave $1 million away to any, frontline person, organization willing to do education with their counterparts. And let me just tell you, I learned and partnered with so many young groups I never even heard of that were doing dynamite work in their social network. I didn't know it, but they were excited about trying to participate, but you had to have resources. I mean, we had people doing rap, related to the vaccine. Oh my God, but they had their folks who normally they socialized with, did a lot of things with. So I think that that's critical. You may not always know who's out there, but if you can provide some resources, they will find you to say, hey, I can do this. Dr. Caine, health department, I can do this. They can tell their physicians, hey, I can do this. You need some help. Let me help you.
Dr. Morgan, I wonder, with the Cobb Institute, do you think that there is any possibility that that either the Cobb Institute or the NMA would be able to be more active in engaging our youngest physicians and our students and training physicians to be able to be more engaged with that rap culture, with that culture of social media influencers? We are a little old in the tooth for that, but I wonder whether we might be able to find a way to better utilize the younger folks in our midst.
Well, I would say for all of us, we know that it takes a village in order to be successful. And to just reflect a bit of what you were stating as far as the clergy was concerned, when you think of going into cities that you don't live in and which you're not very well known, if there's a church that opens up and allows you to bring a program in and helps to bring an audience to that program, then it makes a huge difference. And so from the programs in churches to programs on Saturday morning from 10 to 2, where you had a health fair, we always had a large collection of community. And there would always be the rap going on, and there would be all the young sorors and the various sororities who were working very hard to make the health education fair a success. I think we do have to be more focused and intentional, however. I think we need to work directly with the SNMA, and actually they do a better job of community engagement than we do in the NMA, because that's part of what they have to do in order to get their credits and part of their courses. So I think that they become public health officers before they become MDs. And we need to take advantage of that enthusiasm before they get into residency and lose it. So I think that's one of the things that we can do, is to work more closely with the SNMA. And as I've been on some of the webinars and other programs and have run into all of these amazing young people who have these different ways of communicating, I understand that we have to put them front and center, but that's the only way we're going to really get everyone to buy into what we're selling.
And I think also the nurses that are out there also are incredibly important, and these young nurses are going to be key. I think we're all in agreement that we've just got to be more intentional and more deliberate in augmenting our army in these fights, and being able to just reach out. I would hope, by the way, that Dr. Caine, in your role as president of the NMA, that we might have a chance to even pull together some of these more prominent musicians and entertainers and athletes. Our athletes were absent without leave most of the time. There were some, but very few. And of course, we can understand some of the motivations economically as to why they were perhaps hesitant. But the point being, let's think about whether we can sort of be more intentional in recruiting our capacities in this area. Let me switch over, as we are having this, in terms of lessons learned from the COVID pandemic. We still have ongoing chronic illness problems that have been before pandemic and are there now. Lauren, what do you think lessons that we've learned from the pandemic that will help us to do better at helping our communities, women of childbearing age, be prepared for healthy pregnancies?
Well, certainly the better you are before pregnancy, the better you are during pregnancy. And we learned, as we knew before, that if you already have underlying medical conditions, you're more at risk for having complications related to COVID, particularly in pregnancy. You're more related for severe complications. Unfortunately, one of the things we learned is that pregnancy sometimes can have a much more severe response to COVID than people who weren't. When they're pregnant than people who weren't pregnant. So the importance of vaccines, even now, as we're still dealing with COVID infections, is important. Vaccinations of all kinds, RSV and flu vaccines and pertussis, and those things are to treat not only the mom, but to begin the passive treatment and immunity for the baby before they're born. So that's certainly something. And we've learned now that COVID vaccine is safe in pregnancy. We've had enough data to say it's safe. There's no significant adverse effects to the baby or the mom associated with the vaccination.
And Dr. Caine, I mean, this is what you do for a living every day. What do you think that your take-home messages are as you continue to fight against preventable chronic illness and lessons we learned from the COVID pandemic?
Well, I think the thing is that we have to always remind the public that we have incredible Black scientists and physicians that are really advanced healthcare. When you look at the Moderna vaccine, for example, what Black young scientists, Kamiskia Corbett, who was incredible in helping to design and develop that vaccine. But now, hey, everybody knows that if you're in a car accident or something happens and you are bleeding out a lot, you might need a blood transfusion. Everybody recognizes that might happen in surgery. Dr. Charles Grew revolutionized plasma. So we wouldn't be having the advantage of blood transfusions in the hospital without his scientific expertise. Even developing the first kidney transplant, Dr. Youngs out of New York, downstate, was incredible for the first kidney transplant. I got to mention his name because the brother was graduated from University of Arkansas at Pine Bluff, an historical black college. But we are making these breakthroughs. We are making these advances, and we've got to remind our own people about these incredible scientists that are making these advances, not for just science, but they have mothers, fathers, siblings, colleagues, and that they're doing incredible work. And so
Well,
that's
very
the
helpful.
lesson we got to continue to push out for
Yeah.
our people to recognize and know about this.
Well, let me switch our conversation away from the relationship that Black health professionals need to and did have and will continue to improve on with our community itself, and move towards more individual relationships between the clinician and the patient. And we faced a lot of challenges in trying to convince our patients to follow COVID-related clinical guidance. What strategies did you find to be most effective when offering vaccine recommendations to hesitant patients? And Randall, let me just sort of see where what your experience was.
I think that the most effective tool or activity that we had was to encourage our fellow physicians to take the time to work with their patients, because that's the ultimate trust. And so many of Black patients who were hesitant were not hesitant just because of the fact that they thought something terrible was going to happen. They just didn't understand. And no one wanted to take the time to help them understand. When it occurred, as you said, their vaccination rates were equal, or in some ways, in some communities, even higher among African Americans than Caucasian patients once that spark was lit. So I think it's still the person to person, provider to provider. And unfortunately, we're so short on providers that we have to have all of the levels of working with us. One point I'd like to make: early on with the Cobb Institute, we were working with the National Black Nurses Association, and we had webinars, and we find that 60% of the nurses were hesitant about the vaccine. And so they actually were kind of undoing some of the things that we were trying to do, because they're the ones that are with the patients all the time. And once the nurses began to feel more confident about the vaccinations, I really think that's what began to turn the tide in the Black community. So because we need to have so many mid-level and advanced providers to help us to have these one-on-one relationships with our patients, we have to have a stronger relationship with our nurses.
Virginia, what about you? What were the things that you found to be particularly helpful and useful as you were trying to overcome some of these communication challenges with the individual patient?
So I think the thing you have to know is a different message may be more appropriate based on your age and even your gender. So the message I gave to a patient that was 65 and older was totally different than the message I gave to the young Black male who's a teenager, or he's in his 20s or early 30s. And, you know, a lot of our young Black males, I don't know about what they're like in other states, but in Indiana, they feel that they're very healthy. They never get sick. So why do I need to take a vaccine? And I have to explain to them, hey, it's not about you. It's about, hey, are you in a household with your parents who may have a chronic underlying condition that puts them at higher risk? Or grandparents? And if you are concerned about them, you can have no symptoms whatsoever and have a COVID-19 infection, and you can transmit it to them, where they may end up being hospitalized and in the intensive care unit on a respirator. So it's about you protecting them. But we can never forget about long COVID.
Mhm.
And 19% of patients go on to develop long COVID. And as a young, healthy male patient or female patient, if you say, "Oh, I'll take my chances. I'm healthy. I'll have COVID-19." Well, do you want to be that 19% that can continue to have chronic, severe problems, maybe foggy, brain fog? I can't remember like I used to, and I can't calculate things like I used to. Do you want to be saddled with that, or maybe have chronic arthralgias, joint symptoms, or maybe even heart palpitations now? There's so many organ symptoms related to long COVID. No one, if they could avoid it, wants to get this.
So you found that bringing that up was
Oh,
helpful with some of the people you were talking
that's
to.
what turned the tide for a lot of my patients, the long COVID deal, but more important than that, protecting their parents and their grandparents. And
Lauren,
you
you
know what I
probably had,
also, but here's what you need to understand too.
yeah,
I'll talk
got
to
it.
the parent and say, "Hey, kick your son out of the house. Don't let him come in the house, okay? Hey, they're not concerned about you. Kick them out. Sorry."
Lauren, you probably had as tough a patient population as anyone to try to convince, and particularly as you mentioned in your earlier comment, because of obviously concerns about the health of the baby if they took the vaccine, but also because this is genetics. This is a complicated science. How were you? What did you learn about trying to communicate that kind of information to your population?
I think it's important in any relationship that you're frank. For me to say, I don't know what the effect's going to be. We think it's going to be safe. And even the American College of OB-GYN and the governing body said, have a discussion. They didn't initially come out and say, we recommend it. They say you should discuss it with your patient, discuss their risk factors, and let them come to a decision. I think and I think being frank with them, we don't know. We think it's safe based on this, but we've done that before. We've done that with DES. We've done that with thalidomide, and we've had disastrous, outcomes for the baby. So to be frank with them and talk about what you think is safe. And then it became clear that, at least for me, and other people, the women that we ended up seeing in the ICU were women who didn't have a vaccine, who had significant complications related to COVID, who were on ECMO and on, intubated and other things. And so if you had increased risk factors, to say, if we lose you, we're losing your baby as well. And so to be more aware of the fact that pregnancy, and explain to them why pregnancy makes them more at risk with their relatively immunocompromised situation, and just helping them come to a decision for themselves of what they think the risk versus the benefit ratio is. Now we're fortunate to have a lot of more data behind us to say, yeah, we think it's pretty safe, and we haven't seen any significant adverse effects. We still have some long-term things to look at, but so far, it looks good.
So,
Let's
Reed,
drill in on that.
could I
Yeah,
say
Virginia.
something real
Yeah.
quickly? I think it's important to know that at least the National Medical Association, we did and worked harder on our due diligence. We set up a COVID-19 task force. We wanted to hear exactly from the vaccine developers, tell me about how many Blacks participated in your patient trials. And if you didn't have at least 15% or more, that's what's concerning for us, because we have a lot of sickle cell patients. We have patients HIV, immunocompromised. We have patients who are immunocompromised with a lot of cancers. Our cancer rates are higher disproportionately compared to our white counterparts. So we wanted to know how the vaccine worked on our patient population. And we wanted to hear the information about the safety, give us the side effects related to this. So we were learning as we went on, but we didn't want to jump out there without knowing that information first. And hey, if you didn't have what we thought you needed to have, then hey, we don't want to talk about your vaccine and how safe it is, because you didn't have the numbers enough for us to feel comfortable making those recommendations.
Well, since you
And
talked about the and Lauren, please, Lauren, I'd love to hear what you have to say.
I was just going to say, and I think as Dr. Caine pointed out earlier, it seemed very rushed until you got more information. Oh no, we've been working on this vaccine. It wasn't like we rushed it through. When you got more information about it, as opposed to, oh boom, we just got to get something out, I think people became more trusting of the process than just, and once the information was shared better. So,
And
So you
here's,
really,
here's another thing that people don't realize. A lot of this vaccine development was done related to HIV. So they spent 5 to 10 years working on a vaccine for HIV. So they brought a lot of that work already done early over to help with the COVID-19 vaccine development. And I tell people, hey, I drive I'm in a Ford Taurus, and I love my Ford Taurus. But hey, it evolutionized. If I went back to 1986 or 1980, do you want me to have a car that was 1980, or do you want me to have one that's more evolved to the current one I have now, which is, I think it's 2019, but I bought it.
I think the point though is well made, and I think so. One of the things I'm unpacking from this, from Lauren's comments, is being frank about uncertainty,
Yes.
not and being clear, but also being clear about consequences, and what those consequences will be, and then having engaging in this sort of collaborative conversation. But Virginia, I want you, given that you are the health officer for your county, one of the things that we heard so much about was that this vaccine was going to give you a third ear, a fourth leg, all kinds of crazy stuff. By the way, for the record, are we clear that none of those things, that those horrible things that people thought were going to happen, that these side effects were anywhere close to what people were concerned about?
Never happened. Didn't cause infertility, no. The third thing that we realized over time, that for the folks who didn't get vaccinated, they had a 8 times higher mortality rate than for those individuals who were vaccinated, and double the death rates if you were Black for those who were unvaccinated. So that was kind of disconcerting for people to see, wow, I could have got that vaccine, and they're dying at a much younger age, like in their 20s and their 30s, which was really hard for people to see.
Dr. Morgan, one of the things that you intimated earlier in the conversation was the Black health professionals being involved in the process. We certainly know that, as Virginia mentioned, with Kismeti Corbett being one of the people that helped design the Moderna vaccine, but a number of African Americans were on review committees. How important is it, I think, is the point, in terms of what have we learned about the importance not only of having people of color on various decision-making parts of the process of vaccine design, approval, and dissemination. How important is that, and how important is it to publicize that, in fact, this also occurred?
Very important. And I think that when you go back and look at what occurred and the evolution of how we handle COVID in the United States, the National Medical Association was extremely fortunate to have Dr. Oliver Brooks as president of the National Medical Association at that time, because he was very experienced as a pediatrician, but also with regard to immunization, and spoke eloquently when interviewed nationally. And this made a big difference. This edified, I think, our National Medical Association physicians. And then the COVID task force that Dr. Caine has mentioned has every step of the way evaluated for the last 3 years all of the new vaccines that have come forth. And then we're able to share that information in these communities that I spoke of earlier. So I think we have a tree of information, but to have experts identified gives everyone, including the treating physician, confidence that we have the information. One point I'd like to make, though, is I think it's really important that we speak to the fact that we can't just talk about past tense when we're talking about COVID, because there's the present situation as well. And how do we think about the boosters, and how do we think about the avoidance of long COVID and some of the other complications that can occur today with COVID?
Right. Which is why I think you would agree it's so important that we really codify these lessons that we're discussing tonight and that we're learning, which prepares us for the work we have to do as we, tomorrow morning. Because I think you're absolutely right. Also, I want to remind the audience that we had great physicians like Dr. Hildreth, president of Meharry Medical College,
just going to say,
who is on the FDA review committee and so forth. So I would hope, Dr. Caine, that you, as you and your presidency unfolds at the NMA, that we would make a concerted effort to work with the government officials and others to identify and publicize the roster of Black health professionals who are in positions of decision making.
So definitely, and I just want to give some kudos to Dr. James Hildreth. He's president and CEO of Meharry. He's an MD, PhD. He was a longtime faculty member at Johns Hopkins before being recruited to Meharry. And he was also placed on a special advisory committee to the NIH director for a lot of his work that he's done before in the past. So to have someone with those credentials and that knowledge, being able to hear a lot of information that we don't get privy to on the FDA advisory committee, but also on NIH's advisory committee, is really critical for us.
And also we were lucky to have somebody on the CDC committee as well. So this, I think, is important. Let us move this conversation a little bit to this notion of overcoming distrust. And Lord knows, every town hall that I did, the first question was always Tuskegee or Henrietta Lacks, over and over again. Which one of you'd like to take on? How did you handle the Tuskegee issue?
I will tell you, I heard that a lot. And I heard some people say, you need to get over it. I think it's very important to realize there's reason for mistrust out there. And we can't just disavow it and dismiss it and push it to the side. We have to acknowledge that it's there, why it's there, that it's ongoing. And there's reasons that that's ongoing, and it's affecting health disparities across the board. So I think we have to not dismiss it, acknowledge it, and show how we're working to come together to overcome it.
Virginia, how did you handle it?
I think Lauren is quite right. And I was actually on the CDC's advisory committee to help those third, fourth generations of syphilis patients who have been impacted about what their benefits should be related to. I think you have to be honest with people to tell them this is what actually happened. And the Tuskegee syphilis incident, people don't realize, is that they had a treatment that worked very effectively for curing syphilis, but they withdrew the treatment and gave them basically like a sugar pill. So they didn't get the treatment. And so you had all this congenital syphilis, complications with men dying young from cardiovascular syphilis or brain damage from the neural syphilis. So this was sort of the reverse. And so people were surprised at that, being honest with them. With Henrietta Lacks, that was a different story. She had cervical cancer, and her cells that was developed as a result of her management and treatment at Johns Hopkins revolutionized cancer throughout the country. So she has these special HeLa cells that is really needed, that you can test different treatments against these cells. And academic centers, industry made not millions of dollars, made billions of dollars related to her cells. And yet she nor her family benefited from this at all. So I know there's been some legal ramifications and a lot of education being related to this. So I don't know what the final outcome is going to be. But she made history in terms of advances for cancer, and yet never gets the credit for this publicly. And we have to continue to emphasize and say how she advanced cancer
So I
treatment.
think what you really get to is when we deal with, for example, that kind of a concern, being, as Lauren has said, transparent, honest, empathetic, agreeing. On the other hand, with the Tuskegee experience, one of the things I had the privilege of doing was to interview the descendants, the children and grandchildren. And the thing that was amazing to me, and I interviewed them and put them on film and distributed that film in a lot of places, is that number one, they were vaccinated. And number two, they were more than upset that their family members' pain and misery and suffering was being used to justify somehow not, as you said, Virginia, not taking a drug that would save your life. It makes no, you can't be angry at Tuskegee and then say the way I'm going to protest it is by doing to ourselves what others did to us.
Right.
And so I think that was also, very important. I want to just touch base on what we've learned here in terms of trust and distrust and misinformation around vaccination in general. And Lauren, I am concerned, as you must be, with the number of states now that are rolling back mandates and trying to roll back mandates for childhood vaccination. And so we're starting to see this. How do we address that? And how can we start to make vaccination part of a routine healthcare conversation rather than something we react to when there's outbreaks?
Well, I think, again, knowledge is power. And the more we get out, not in the moments of crisis, but on every day, pick a topic, whatever topic. Each week we're going to get out there and we're going to build these relationships with the resources, like as Dr. Caine pointed out, of community services and resources that are already out there, that we are working in partnership to educate them on the safety, on the use, on the benefits, on the risk, and they can make their own decisions, not force them into decisions. But I think once people understand the concerns, a fair amount of them are going to say, well, yeah, this seems to make sense for my children and for my, during pregnancy and outside of pregnancy, that this is going to be beneficial to my family. And I think women, are the safekeepers or the guard keepers of their families. And so pregnancy is an optimal time to start those kind of discussions and continue them on as after pregnancy.
And Randall, how would you, from the perspective of the Cobb Institute, sort of think about this notion of how we involve vaccinations as a normal part of the clinical experience?
Well, yes, I think that's extremely important. And really today, the COVID vaccine hesitancy that is present stems more from today's health inequities than it did from the historical inequities. As we speak, every year those become further and further in the past. So the concern that we have is that treatable diseases now are becoming a problem again. Polio, measles, because of the pervasive effect of the anti-vax that was presented by COVID. And so we have to work on both ends of the spectrum to try to make sure that the childhood vaccinations are, given in all states at the appropriate times. And so that means more of a coalition working with the pediatricians as well. So I think there's a lot on the obstetricians and the pediatricians right now to try to at least keep us in safe spaces, particularly with regard to children. That's a major concern of mine.
Well, I think Dr. Caine, by the way, I want to remind our audience that we appreciate those that have written in comments or questions, and certainly feel free to do that. We are encouraging that feedback from you. Dr. Caine, again, back to from the perspective of the NMA, do you think that we can? Do you think we have the opportunity for our various chapters in those states where they are attempting to roll back, the mandates for preventable childhood illness related to school age children, et cetera? do we have an opportunity or a responsibility to sort of mobilize to address those things at the legislative level?
So there's no doubt about it. We have a role and responsibility to advocate for our patients, to help advance good policy for our patients that improves our outcomes and our advocacies. And we got to step up and speak out when someone is providing incorrect information that impacts the very patients that we save. And it's just not for Black patients. This is for patients, every racial and ethnic population, when we're making these recommendations. And so, recently we heard in the state of Florida that someone was making recommendations not to a healthcare official not to take a messenger RNA vaccine related to COVID.
Dr. Caine, let me interrupt you and just say it wasn't just somebody. It was somebody in a position of extraordinary influence and authority, and especially given that somebody was the state health commissioner.
Yes, so incredible, I think, in terms of when you just examine the data, evidence-based science data, and from the leading academic institutions, how do you make a recommendation like that when you look at the mortality rate for those individuals who do not get vaccine? And I say again, we have a lot of cancer patients. We have a lot of patients who are immunocompromised, who are at a much higher risk to not only be hospitalized, but to end up in the intensive care unit requiring a respirator when this vaccine can prevent the more severe complications. It may not prevent you from getting it at all, but you want to reduce your risk of having to be hospitalized, but more important than that, ending up in an intensive care unit.
Well, Dr. Caine, you've actually presaged one of the questions that had just come in from our panel, from our audience that I have, and that is the role of Paxlovid. How do we need to talk about that, especially given that it requires, of course, a relationship with a healthcare professional?
So this is a huge problem for us. So when you look at the poverty level of Blacks in this country, the poverty level is about 20% meet the poverty guidelines. And so they don't have health insurance. They may not even have a primary care provider as such. And so we know that Paxlovid is a medication that is recommended that if you have COVID-19, you've contracted COVID-19, you have less than 5 days to be placed on this medication because it substantially, by almost 75%, reduces your risk for hospitalization and even maybe ending up in the intensive care unit. But guess what? CDC ended their Bridges program that would provide free medications for you if you had no insurance and you couldn't get it. And do you know what the cost of this drug is? Retail, no insurance. It's nearly $1,500. Whether it's, I'll just talk about the leading pharmacies that I looked at, CVS or Walgreens or Walmart, just to name a few. The cost is almost $1,500. So now tell me, how can someone afford that? And they got 5 days to find a primary care provider and write the prescription for it. But hey, writing the prescription is not going to help me get that medication. Now, pharmaceutical industry will tell you, hey, you can fill out a patient assistance form and you can get this medication. Well, if you don't have a primary care provider, who's going to fill out that patient assistance form? Who's going to help that patient get this medication? So we need to solve this problem. The NMA needs to develop a policy. We're looking at this real quickly to say, how can we find an easy way for someone who doesn't have the money or insurance to have them be able to get this access of this medication in 5 days at relatively no cost?
And I've been pushing on my work hard, trying to remind the community up front how important it is to establish a trusting relationship with the clinician, because you don't know when you're going to need it. And as you said, you don't have much time. We only have a couple of minutes left. But let me just ask this question of you all on behalf of our audience. And that is, things moved very quickly in the pandemic. Knowledge, information changed very consistently and regularly. It was trying to keep up with the speed with which information was coming at us and being able to evaluate the veracity of the information. So many medical centers and researchers put out these preprints into the public that were not subject to the adjudication by the editorial process before we saw it. How did you learn and keep up with the learning? Lauren, let me start with you. How were you able to keep up with what was going on? Or did you feel like you were able to keep up with what's going on?
I always felt a little bit behind. It's like, boom, preeclampsia went out the wazoo with this. And so I felt like you're running around labor and delivery units and just treating patients, but trying to keep up. We had special task forces that would report to us. And so that was very helpful, and just reading and listening and just trying to gain as much information. But I will be frank with you, at the beginning, I didn't feel like I was on top of anything. I was just praying and moving forward the best I could.
Randall, your thoughts?
Well, during that same time, I was introduced to the National COVID Network out of Seattle, and between Seattle and Hopkins, and each week they would have updates. And my colleague, Dr. Doris Brown from the National Medical Association, and I were religiously on those calls every week. And it really helped us to support the programs that we had for information for NMA. And we were able to just be really on top of all the changes, and also understood which clinical trials were most promising. So we sort of got the front view and the back door view as well. And I hopefully that will start again, because I think it really brought a lot of us up to date at a very comfortable time. You could have your lunch and watch. So that was a great opportunity for me personally.
And one of the things that we will have to be very careful about, of course, is separating out truth from fiction ourselves so that we can communicate that well. Virginia, in 10 seconds here, as a public health person, I still trumpet, and I wonder whether you will endorse that, but I still trumpet the CDC as being the go-to place, even though we know they had their challenges just as everyone else did. But I find no reason not to see them as the go-to place to learn first, and then other places supporting that. Am I on the right track here?
They are just top notch, and the level of expertise recently that they have added to their agency, and the communications are getting out much more rapidly, and they're doing a great job of doing community engagement with healthcare professionals across all of the different spectrums, whether it's the National Medical Association, National Hispanic Medical Association, Asian Pacific Islanders. They are on it, and they're really pushing their scientists. So we saw at the start of this epidemic that they were downsized by 40 scientists, well-known experts, and they got downsized at the start of this pandemic when we needed them the most.
So, well, thank you all. I'm going to have to end it there, but this has been a very interesting conversation for me. I've enjoyed listening to all three of you. One point that I did not make during our conversation about the Black health professional and the community is that there are bills that just been introduced into the Congress to support real funding for consistent community and faith-based infrastructures in our communities. And I hope that that will be finding its way to the agenda of the NMA. I want to thank each of you so much for your insight. I really want to again thank Moderna, who has been there multiple times when we needed the money to produce town halls for our community. They have always been there to support us, and we greatly appreciate it. I want to thank blackdoctor.org for the role that they play. I did 30 town halls myself during the pandemic with blackdoctor.org, and Dr. Renee, you are terrific, as is the rest of that team, and you all are providing such a public service to our community. And finally, let me thank our audience. You are so important. And as Dr. Morgan has indicated, this pandemic, while it's no longer a pandemic, COVID still rears its ugly head every moment. We have issues and challenges to help protect the health of our people, starting again tomorrow and the day after that, and the day after that. And if if COVID wasn't bad enough, think about the burden of preventable chronic illness that was pre-COVID and certainly has been exacerbated and is with us today. I am so proud to be a Black health professional. I love being a Black health professional and all that the responsibilities and the accountabilities it entails. Thank you, audience. Thank you for what you do every day on behalf of our people and on behalf of this country. Take care, everybody. Bye-bye.